Our PICO question is, do patients with surgical wounds who receive extra pre- and postoperative measures to reduce surgical site infections have fewer postoperative infections than those who only receive the standardized pre- and postoperative measures? Surgical site infection is defined by the CDC as an infection of the surgical site following a surgical procedure. These surgical site infections are classified as superficial incisional, deep incisional, or by the organ and space involved.
So, after doing a little bit of research, it turns out that the answer to our PICO question is yes. Individuals who undergo extra pre- and post-operative measures do indeed have fewer surgical site infections than those individuals who undergo the standard pre- and post-operative measures. In one study that was implemented by using wound barriers during abdominal surgeries, it was found that the incidence of surgical site infections with the wound barrier being used was only 4.7%. And when the wound barrier was not applied during surgery, the incidence of the surgical site infection was 22.7%. In a second study, patients admitted for a total joint procedure used a skin antisepsis protocol incorporating 2% CHG, no rinse cloth, to do a site-specific wash on the night before surgery and in the holding area just before surgery. In the 3 quarters before implementation of the protocol, the SSI rate was 3.19%. However, in the 3 quarters after the 2% CHG cloth was introduced, the SSI rate decreased to 1.59%, representing a 50.16 reduction in SSIs. And in another study, patients underwent nasal swabbing, and this was a screening that was done days prior to surgery to see if there was an active culture of MRSA in their nasal passageways. The patients that tested positive for NSA underwent nasal treatment with a 2% mupirocin intranasally twice a day. Repeat screenings were obtained from the MRSA patients before surgery, and it revealed that there was a 78% eradication of the nasal MRSA, proving that the extra steps taken prior to surgery indeed cut down on the risk of surgical site infections.
So we were able to find some statistics that kind of help us identify this problem. So the CDC estimated that 22 of all healthcare associated infections were surgical site infections. The CDC also said in 2001 that almost 300,000 surgical site infections happen every single year, and that got them to estimate between 1 billion and 10 billion in medical costs. Additionally, there are approximately 8,000 deaths that have been associated with surgical site infections, so there's an increasing incidence and the extent of the injuries that are happening, and it's increasing the healthcare costs of these surgical site infections to treat them after they happen. And due to this increase in prophylaxis relating to surgical site infections should be a priority. This is something that really is a problem that we need to be looking at. So while our group was looking into this problem, we came across this article that we really think is helping contribute to the problem. So this survey comes out of Queensland, Australia, and it is a self-reporting survey that a bunch of nurses took about acute wound care. And so there were lots of statistics that came out of it, but we've listed the 4 big ones. 25% of nurses self-reported that they had inadequate knowledge of the dressing products that they were supposed to be using. So you can't imagine that they would be doing all of their dressings exactly right if they don't even know how to use the products that they have. Also, 50% stated that they were unaware of the National practice standards. 75% said that they used a wound care specialist as a primary source for wound care evidence-based practice, which sounds okay, except for if 50% don't know the national standard practices, then you're not absolutely sure that those wound care nurses know exactly what they should. And then 73% incorrectly identified the recommended postoperative time period. So what that means is there's a standard that you're supposed to change the dressing 1 to 3 days post-op from the original dressing, and a lot of these nurses were waiting 5-7 days, and that obviously is going to make it so that they're getting more infections. So why we think this is such a big contributor is not only are these nurses not doing extra to help prevent infections, but they don't even know what the minimum standard is, or 50% of them don't know what the minimum standard is. And so that's probably contributing to a huge amount of these infections that we're seeing.
Hello. Hi, Mr. Ramirez. My name is Rachel, and this is Miranda. We're going to get you ready for your surgery. You are having surgery today, right? Oh, yeah, that's what I thought. Your name is Mr. Ramirez, right? Here, yeah, let me... Okay, yeah, that is you. All right. Okay. Well, we're just going to be doing a few things to make sure that we're ready, okay?
Okay, so your name is Mr. Ramirez, right? Okay, so we're just going to ask a few questions. You're having surgery on your thigh? What's going on here? Okay. So I see that you had a past of smoking. Have you smoked in the past week or so?
Oh, so yes, you had a cigarette this morning?
Okay, well I'll let your doctor know. We'll see how it goes.
Yeah, that should be fine. It should be okay. And you're supposed to be NPO at midnight. I just want to double check with you to make sure that you didn't eat anything or drink anything. Oh, you had a piece of toast this morning. How long ago was that?
We're real good at following directions.
About an hour ago? Well, you know, that should probably be okay. We'll let the doctor know. It should probably be fine.
I see that you had been on a steroid inhaler in the past also, which is kind of a red flag. Have you been using that lately since we asked you not to?
Oh, you brought it in. You used it this morning? Also, did they put something in your nose? We do this thing, it's called NARS testing. We're just kind of looking for like microorganisms and stuff in there. Did you do that? Oh, you haven't done that? Well, you know, it's okay. We don't technically have to do that, so that should be fine.
It's kind of a new age thing. I'm not really sure if they're using it.
Yeah.
Have you been taking the baths with that solution that we gave you? Okay, so you just took like a regular bath this morning. Okay, I mean, honestly, I really don't think that you need to do that because they're going to wash you after a while in surgery, so it's probably fine.
Yeah, you should be fine.
Mr. Ramirez is needed for surgery. Transport's on their way.
All right, well, looks like they're about to come get you. I think we're good to go.
Yeah, did we go over that checklist? Yeah.
Do you want to go? We're good.
You should be fine. All right.
Hello, Mr. Ramirez. How are you today?
We're here to take a peek at your wound real quick. I know that it's been on for about 5 days now, so we're going to just look at it, check it out for you.
How's it been going? Okay. Is that hurting at all? I mean, it doesn't look like it feels very good.
No, there's a little bit of odor with that too. I've heard you've had a bit of a fever too. Oh, I'm sorry. That must have hurt a lot. Huh.
All right. Well, what would you say your pain rating is on a scale of 1 to 10? Okay. Well, does it only hurt when I touch it? All the time. Okay. So, we'll get a doctor's order to get you some pain meds, and we're gonna need somebody to come in and swab this and see what's going on. Should we go ahead and get dressed in?
No, they're gonna swab it. Let's just leave it. It should be okay.
Yeah, they're gonna come in and swab it and see what's happening with you, so we're just gonna put all this back on there.
Yeah.
Okay. All right. Well, good luck.
Yeah, they should be back in here soon, hopefully. So, yeah.
I think you did not.
When speaking of the standard pre-surgical measures taken to prevent SSIs in patients, some of the most common ones that you will see implemented in the hospital or other healthcare settings are nasal swabbing. And this type of nasal swabbing typically will take effect the morning of the surgery. There will be patient skin cleansing, and this typically includes the patient showering the night before and the day of the surgery with the facility's recommended disinfectant soap. Hair removal takes place as well, and this is performed the morning of the surgery in the area that is to be operated on. IV antibiotic timing is another standard pre-surgical measure that is taken, and it can either be initiated upon 60 minutes prior to the incision if the medication being used is cefazoline, cefuroxime, or clindamycin. It can be done 120 minutes prior to the incision if the antibiotic being used is vancomycin. And these infusions of antibiotics are to be completed at a minimum of 10 minutes prior to tourniquet inflations. Identifying and treating infections remote to the surgical site prior to surgery is implemented. Checking the hemoglobin A1C in patients with diabetes and blood glucose levels is also implemented. This is done because you want to avoid hyperglycemia during perioperative phases. And you typically want to control the serum blood glucose levels less than 180 milligrams per deciliter in diabetic patients. The reason behind this is because hyperglycemia reduces the body's natural resistance to infection. Another pre-surgical measure is assessing renal function. You want to keep the preoperative hospital stay as short as possible, and the reason for this is the longer the preoperative hospital stay, the higher likelihood that the patient could possibly be exposed to a nosocomial infection. And then also, you want to encourage your patients, if they know that they are going to be having a surgery ahead of time, you want to encourage tobacco cessation. And as nurses, we encourage tobacco cessation, just standard with anybody that is smoking, but especially with patients that are to undergo surgery, because the nicotine in tobacco results in a microvascular vasoconstriction. In addition, it also causes tissue hypoxia, and this can be a contributing factor to the development of a surgical site infection. All right, also some standard post-surgical measures taken are that the incision must be primarily closed with a sterile dressing for 24 to 48 hours post-operatively. You want to perform hand hygiene before and after dressing changes. The use of sterile technique when changing dressings is very important. You also would like to educate your patients on proper incision care, symptoms of surgical site infections, and to report any of these symptoms to their healthcare providers when they have returned home. The practice of strict hand washing prior to contacting patients' IV sites is very important. You want to ensure that antibiotics are given on time and that all are taken when the patient is going home. And then you would like to monitor for and to instruct the patient to report any signs of renal failure. And some signs of the renal failure that you will be looking for are the blood urea nitrogen levels, the creatinine level, and their intake and output is very important as well, along with the urine color.
Now we have some time to talk about the clinical relevance. So on this first slide, we have some statistics. Up to almost 356,000 surgical patients develop SSIs after their orthopedic surgery every year. And additionally, we have a quote from Barnes that says, "The focus on SSI prevention has never been more important given current trends in healthcare, including the ongoing shift from inpatient to outpatient ORs, non-reimbursement for healthcare-associated infections, and mandated public reporting of infection rates in some states. A sustained zero infection rate remains an elusive goal." We have a quote here that is talking about the organisms that are associated with SSIs. So Spencer says that MRSA in healthcare settings commonly cause serious and potentially life-threatening infections, such as pneumonia, bloodstream infections, and SSIs. It occurs most frequently in patients undergoing surgical procedures, patients with weakened immune systems, and those undergoing invasive medical procedures. Just to add some more to clinical relevance, we have the Joint Commission chiming in. As you may know, many hospitals strive to be accredited by the Joint Commission, and they publish each year a set of goals that they're working for towards their hospitals. So we included 9 of the 15 goals for 2015 in hospitals, and we included those 9 because they are related to infection prevention and surgery. And we think that this is very important because if over half of the goals are hospital and infection related, then this is obviously a huge focus of the Joint Commission, which means it's a pretty big deal. Our last piece of clinical relevance we think is going to be really big in the future. This team came up with a new algorithm to track SSIs so they can enter these results and these qualities into a database and pull out lots of medical information about people that most likely got SSIs. And this is really important because it's going to, in the future, help us more accurately track how many SSIs there are so that we can keep a good eye on this problem.
The solution is to add these extra measures in addition to those standard pre- and postoperative measures. Nasal swabbing is used to screen patients to see if they are carriers for MRSA or MSSA. This measure should be done 14 days prior to the surgical procedure. Pre-operative patient skin cleansing should be done for 5 days in a row prior to surgery. This should also be done the morning of surgery. This is done with a chlorhexidine gluconate solution. Pre-operative dental screenings are also very important because they evaluate for tooth decay, inflammatory gum disease such as gingivitis, periodontitis, or dental abscesses, which may lead to deep joint infections after surgery. When assessing the patient, we should find out if they are currently on any steroids or immunosuppressants. If the patient is currently taking either of these medications, the use should be tapered prior to surgery. Also, upon assessment, we need to assess for malnourishment, since malnourished individuals have an increased risk for surgical site infection. During the actual surgical procedure, barrier devices should be used. As far as additional post-surgical measures, we should use the chlorhexidine solution once again for cleansing skeletal pin sites. Below there is a link to a YouTube video which will further explain these additional measures.
Going along with the solution of taking extra pre- and post-operative measures to decrease the rates of surgical site infections, there are other modifiable risk factors for these infections that can be taken. With obesity, the patient is in anticipation of a surgery and has ample time to do so. Weight loss should be encouraged if the patient is obese, because obesity can contribute to an increased rate of surgical site infections. If a patient is at risk for MRSA, preoperative testing and treatment up to 14 days prior to surgery should be taken to see if the patient is in fact a carrier of MRSA. If anemia is anticipated preoperatively or postoperatively, a couple of things to do is to have autologous or allogenic blood ready on hand to be infused, or individuals could also increase their iron intake days prior to the surgery. With smoking, for patients that are smokers, they should be encouraged to cease smoking up to 30 days prior to surgery to decrease the risk of the vasoconstriction, which can lead to surgical site infections. With malnutrition, you want to ensure that your patients, they have good nutrition so that their albumin levels are at an adequate level so that the healing can occur and the risk for infection will decrease. With diabetes, diabetics should regulate their blood sugar by healthy diet, exercise, and also by using pharmacological measures, so taking metformin or their insulin, just to keep that blood sugar level low enough prior to surgery, because if they are hyperglycemic, that impedes the body from fighting off infections. With HIV, it is encouraged that the patients should be on their retroviral medications and also, taking antibiotics or the standard precautions to prevent infections, such as just good hand washing, good hand hygiene. With rheumatoid arthritis, patients would want to take measures to decrease the inflammation in their joints, so pharmacological measures. With remote orthopedic infection, take extra precautions prior to surgery, such as the CHG cleansing days prior and the night before and the day of surgery to prevent these remote infections in orthopedic patients. Poor oral health. This is something that people should also definitely take into consideration, which can commonly be looked over. Patients, they need to go to the dentist regularly and practice good oral hygiene, because if this isn't done, the bacteria in their mouth can also sediment and settle in their joints and just set them up for the risk of having an infection. And lastly, with urinary tract infections, some modifiable risk factors for that is patients, they just need to practice the correct wiping methods. For women especially, encourage them to wipe front to back, not back to front, just so that that bacteria doesn't cause a urinary tract infection, and to have good cleaning in the perineum area. Also, with urinary tract infections, you want to encourage your patients to stay hydrated. That way they will have good output, because if urine becomes stagnant in the bladder, it sets individuals up for a urinary tract infection. So encourage your patient to drink lots of fluids and urinate frequently. And for healthcare providers, oftenly post-surgery, these individuals, they're going to have Foley catheters in, and we want to practice sterile procedure when inserting these Foley catheters. UTIs are a very high rate in hospitals, and just if sterile procedure is practiced with the insertion of these Foley catheters, we can really decrease the risk of the urinary tract infections. So altogether, these are all modifiable risk factors that can be taken upon each individual to just decrease the risk of infections.
As earlier mentioned, a big contributor to the problem is of nurses being unaware of standards and of wound products. The solution to this part of the problem would be to require additional education to the nurses on the units with wound care. It would also be helpful to distribute reference materials of these standards.